Good afternoon and welcome to this month's webinar, Delivering Community-Based Support for Drug Use and Mental Health Disorders. As we gather, a number of housekeeping matters. The first is that the content of the webinars is the responsibility of the presenters, and the presenters' views do not necessarily represent the views of the Association of Justice Treatment Professionals or the International Association of Treatment Courts. The panelists are reminded to keep their microphones muted when they are not speaking and unmuted when they are speaking. We love to hear from you, and in fact, dialogue is a very important part of these webinars. However, we will answer questions at the end of the webinar. So make sure to engage using the Q&A button at the bottom of the screen to interact with our panelists. At the end of the presentation, we've left some questions for some time for questions, and we will answer your questions at that time. Also, the Association of Justice and Treatment Professionals and also the International Association of Treatment Court Professionals tries to provide a forum to share ideas and best practices in places where justice and treatment intersect. This webinar is one of those activities. Connect with these organizations to ensure that you never miss a webinar. You can connect on Twitter, LinkedIn, and you can also subscribe to the mailing list at justicetreatment.org. A recorded version of this webinar will be available some 5 to 7 days from today at the justicetreatment.org website. At this point, we'd like to thank individuals who have made this webinar happen. And in fact, I would like to remind panelists to ensure that all their microphones are muted at this time. But what I'll say is that I would like to thank the organizing committee, Jessica DeCuna, Jennifer Graham, Assistant Crown Attorney, and we have Andre Rivard of Duty Counsel, Erin Smith, and of Park. I'm going to try and go back to the list. We have Kim Briggs, Justice Services Case Manager at the Canadian Mental Health Association, Elgin County. And I told you about Erin Smith, who is a counselor and case manager at the Peel Addiction Assessment Referral Center, and also myself, Justice Barnes. Now, looking at the numbers, enough of us have now gathered, and it's appropriate at this time to do the land acknowledgement. Erin Smith will do the land acknowledgement at this time.
Thank you, Your Honor. So we will begin this webinar by acknowledging that we are meeting on Aboriginal land that has been inhabited by Indigenous peoples from the beginning. As settlers, we're grateful for the opportunity to meet here, and we thank the generations of people who have taken care of this land for thousands of years. Long before today, as we gather here, there have been Aboriginal peoples who have been the stewards of this land. In particular, we acknowledge the Anishinaabeg, Huron-Wendat, Haudenosaunee, and Ojibwe Chippewa peoples, the land that is home to the Métis, and most recently, the territory of the Mississaugas of the Credit First Nation, who are direct descendants of the Mississaugas of the Credit. We recognize and deeply appreciate their historic connection to this land. We also recognize the contributions of Métis, Inuit, and other Indigenous peoples who have made both in shaping and strengthening this community in particular, and our province and country as a whole. As settlers, this recognition of the contributions and historic importance of Indigenous peoples must also be clearly and overtly connected to our collective commitment to make the promise and the challenge of truth and reconciliation real in our communities. In particular, we would like to bring justice for the lives lost in residential schools, as well as all murdered and missing Indigenous women and girls across our country. Thank you.
Thank you, Erin. I'd like to begin by just telling a story about Jonathan, who is 16 years old. He is described as charismatic, friendly. He's a kind young man, handsome, an all-round athlete. By the time he was 17 years old, he was a high school track star. He was also a football star. It was not unusual for Jonathan and his 5 close high school buddies to smoke marijuana after school. In fact, they were heavy smokers. When Jonathan was about 17 and a half years old, his friends noticed that he began to smoke marijuana more often without them around. They also noticed that when they smoked marijuana with him, he became quiet, withdrawn, almost as if he was in a trance. Jonathan's parents noticed that he would be moody, talking to himself. They reported that when they returned home from work, they would notice Jonathan in the basement, huddled in a corner, talking to himself with the windows all covered to make the basement very dark. This seemed to happen anytime Jonathan smoked marijuana. His friends did not exhibit the same symptoms after smoking marijuana. Jonathan has become withdrawn. He speaks to himself, speaking to people no one else can see. His grades are failing. He's prone to violence, and he's cut off friends and family. Someone told his mother that Jonathan may be suffering from a concurrent disorder. Jonathan has not been assessed by any qualified professional. What does a concurrent disorder mean? How can the worried parents get help for Jonathan? What resources can they access? Our panelists may not talk about Jonathan directly, but they will help us navigate these issues. Lindsay Reynolds is a registered psychotherapist, clinical education lead, addictions at Lake Ridge Health Hospital. She has 20 years experience working in addictions and mental health clinical education. She's the lead for the Community Substance Use Services Program at Lake Ridge Health Hospital in Oshawa. In that role, she assists with knowledge transfer. She promotes the uptake of best practices in treating substance use and concurrent disorders. She leads implementation and supports system change and CLEs, as are viewed by teams as having a reliable systemic strategy to facilitate guideline implementation. Nathaniel Israel just describes himself very simply, that he's got a master's degree, that he's got a bachelor's of science degree, and that he's a clinical director and a registered psychotherapist working in the virtual outpatient program, Trafalgar Addiction Treatment Centers. I believe he's the clinical director of that virtual outpatient program. And then Alex Yeman is a registered psychotherapist and has a master's of criminology. He is a youth mental health court worker and the project lead for the Pathfinder Screening and Referral Service at the Ontario Court of Justice at 311 Jarvis. I remind the panelists to keep their microphones muted. Questions, keep them coming through the Q&A. Ms. Reynolds, we'll start with you.
Hello, thanks for the introduction. I am just going to share my screen. Let me see here. Can you give me screen sharing permission?
Okay. Right now, you're supposed to be able to do it. You're having difficulty with that, right?
Yeah, there's no option to share my screen anymore. Oh, there we go. Got it.
There you go.
Okay. Yep.
Okay.
Thank you.
Okay.
Sorry about that.
That's good.
Okay. You can see now. It's a little bit different presenting these days because you can't see your audience. So just stop me if anything goes wrong. So I'm Lindsay Reynolds. I'm the clinical education lead at the Community Substance Use Services at Lakeridge Health. Okay. I have no conflicts of interest to disclose. And in talking about concurrent disorders, I had wanted to talk about some terms. So mental illness is a sort of defined as a disturbance in thoughts and emotions that decrease a person's capacity to cope with the challenges of life.
Right.
This is a general.
No, just a second. It looks like we cannot see your screen. We cannot see your PowerPoint.
No? Okay, let me see here.
See if it, there you go.
You can see now?
Yes, we can.
Sorry about that.
Perfect.
So mental illness, like I was saying, is a disturbance in thoughts. It decreases a person's capacity to cope. But this is a general description and doesn't necessarily disclose all of the symptoms that may be available. Sorry, I'm just going to pull up. I'm not able to see my notes section here. Okay. So the next term that I had wanted to talk about was substance use disorder. So this on your screen is a clinical definition of a substance use disorder, but there's a wide range of behaviors associated with addiction. And this can sometimes just simply be defined as behavior despite consequences. For the purposes of this discussion, let's just stick with talking about addiction in terms of substance use and avoid the common behavioral addictions like gambling. So the DSM-5 allows clinicians to specify how severe or how much of a problem the substance use disorder is, depending on how many symptoms are identified. So 2 to 3 symptoms indicate a mild substance use disorder. 4 to 5 symptoms are a moderate substance use disorder, and 6 or more symptoms indicate a severe disorder. Concurrent disorders are sometimes called co-occurring disorders, and that's a term that refers to an individual that has both a substance use concern as well as a mental health concern. So Medify informs best practices for substance use in Ontario. Medify stands for mentoring, education, and clinical tools for addiction. And Medify was developed by Women's College Hospital in Toronto. The purpose was to support clinicians across Ontario in delivering high quality care to people with substance use disorders in all care settings. So they provide clinical education, training, mentorship, networking. They run an online community of practice for addiction questions and case discussions. They create and implement provincial standards for addiction treatment, and they've been recognizing as providing best practice information to clinicians in treating people with concurrent disorders. So, hold on a sec. I think I might have skipped some slides here. Did I? No, I did skip some slides. Sorry about that. Oh, I lost a slide. Sorry. So I wanted to talk about Quadrant 3 substance use disorder. So my slide is missing though, unfortunately. So where did it go here? I'm so sorry. So So quadrant 3 substance use disorders, there is a quadrant model of addiction treatment. So the first quadrant is people who have low substance use, low mental health issues. The second quadrant is high mental health, low substance use disorders. And the third quadrant is people who have sort of milder substance use, or sorry, sort of mild mental health issues and higher substance use disorders. So the best practices in treating quadrant 3, the reason I had chose quadrant 3 is because to talk about concurrent disorders in a 10-minute presentation, it's a very large topic. So I sort of wanted to narrow down to people with milder mental illness and more severe substance use disorder. So best practices for people who have quadrant 3 substance use disorders are a combination of counseling, medication, harm reduction strategies, and withdrawal management support are best practices to help people who are ready for change. So the first line of treatment in substance use disorders related to alcohol, opioid, benzodiazepine, or other sedative drugs is medication. So medication is used to help with withdrawal symptoms and to prevent cravings. The second line of treatment that can be considered is counseling, harm reduction strategies, such as access to naloxone kits, fentanyl test kits, as well as other behavioral supports. In Ontario, people with substance use disorder can access RAM clinics, rapid access addiction medicine. We see from this model that RAM receives and provides referral from psychiatry, family physicians, hospitals, and withdrawal management units. So RAM clinics are open to community members with any sort of substance use disorder. People can be referred from a hospital, a clinic, a community agency, but they can also be self-referred, and they should be seen within 7 days, but ideally under 3 days. The clinic staff include a physician or nurse practitioner who's capable of prescribing anti-craving medications. There should be a counselor, case manager, or nurse who can provide assessment, referral, and brief counseling. The interventions tend to be time limited and oftentimes include a referral. Staff provide counseling at each visit that is trauma informed and based on principles of motivational enhancement and solution focused therapies. Staff provide counseling and treatment for anxiety, depression, PTSD, substance use induced psychosis. The clinic will refer to psychiatry and to other community agencies for more intensive formal treatment of mental health issues when warranted. Harm reduction supplies and resources are available at each RAM clinic visit. So Lakeridge Health is a very large community hospital that spans Durham region. We have quite a large group of teams capable of providing care for people with type 3 concurrent disorders. All of the programs I'm going to discuss are ministry funded, and most of these programs accept self-referral, meaning you can just call and set up an appointment with the program. So community treatment is an outpatient program that provides assessment, referral, and counseling for people with substance use, gaming, and gambling concerns who are aged 11 and up. They serve youth, adults, and they also provide treatment and support for family members. Intensive opioid case management is a program that provides support for people who are primarily struggling with opioid use. Residential and community withdrawal management services are sometimes referred to as detox. So they provide assistance with detox for clients age 15 and older. The average length of stay is 3 to 5 days. And at Lakeridge Health, they have access to a physician, nursing staff, and addiction counselors. The addiction counselors and nursing staff are there for the most part 24 hours a day. We have a rapid access addiction medicine clinic with a physician, several nurse practitioners, an advanced practice nurse, addiction counselors, clerks, and other support staff. We have an addiction medicine team, which is an acute hospital-based support that identifies, provides linkage and best practice recommendations for people with both substance use and concurrent disorders. There's a physician, advanced practice nurse, addiction counselors, and substance use navigators on the team. And we're lucky enough to have a women's residential program, which is a 21-day residential treatment program for women with Quadrant 3 concerns. Again, people with milder mental health issues and with more severe substance use disorder. So I wanted to talk about a case study. This is a common presentation at Lake Ridge Health. So Joe is a 24-year-old male who comes to the emergency department with symptoms of opioid withdrawal and low mood. He states, "I feel so sick, I just want to die." He reports using heroin by nasal inhalation and decided to quit cold turkey about 4 days ago. He really wants to make a change. He clarifies he doesn't want to end his life, but his mood has become so low related to his heroin use and sickness from withdrawal. So what are the best practices in this case? So Joe should immediately be provided with medication by his emergency department physician to treat opioid withdrawal. He should be referred to the addiction medicine team and evaluated by a substance use navigator for support during his visit. The role of the substance use navigator would be to offer immediate case management support, ensuring Joe has his basic needs met, including food, clothing, shelter. The substance use navigator ensures that the care is free of stigma in the department and provides best practice reminders to interdisciplinary teams. The substance use navigator can work closely with Joe and his family if he wishes to offer additional system navigation. So once Joe's withdrawal symptoms are managed, his mood can then be evaluated by the emergency department physician to determine if he requires a psychiatric evaluation during his visit. He can also be offered a consultation with our addiction medicine team. When Joe leaves the hospital, he should be he should receive a prescription to manage his withdrawal, to prevent cravings, and to prevent overdose in the future. He should receive an naloxone kit. He can receive harm reduction information, which includes information about overdose risk, infection prevention, and how to take his medications. He should be offered a follow-up appointment with the RAM clinic. He can be offered the cell phone number of his substance use navigator, and he and his family can receive additional system navigation and answer any questions after he leaves. He can receive an offer to participate in the counseling program with the opiate case management team. And he can also be given information and an offer to receive care at our residential withdrawal management program or detox if he feels he requires it. So within 3 days, he should have a RAM clinic appointment. Within 2 weeks, he could potentially have his counseling appointment. And throughout that time, he can connect with his substance use navigator for additional support. So when searching for treatment for concurrent disorders, it's best to use resources that provide best practice system navigation and support. So I really trust Connects Ontario as well as 211 Ontario. If you have a client, a loved one, or even for yourself that requires support for their concurrent disorder, you can use the web browser, the web chat, or the telephone number for Connects Ontario and 211 Ontario. Thanks so much for listening, and I look forward to listening to the other presenters.
Lindsay, thank you very, very much. And we shall be hearing more from you. So Nathaniel Israel is next.
Hello, give me 1 second as I share my screen. Okay. 1 second. Okay. Good afternoon, all. Good afternoon. Thank you very much, Lindsay, for that nice introduction and your lesson that you brought forth thus far. Just like Lindsay, I generally speaking, enjoy speaking and seeing people face to face, but I'm going to roll with it. And one of the aspects that I'm going to roll with is what Honorable Justice Barnes had brought up with respect to that case study or the actual real life example of Jonathan. Jonathan that, started to use cannabis as a means of social camaraderie, right? Then became a little bit more avoidant, then became a little bit more recluse, starts to depend upon cannabis use, and then maybe even develop some elements of psychoses. So here at Trafalgar Addiction Treatment, we try to actually target or get ahead of the curve prior to that severe psychosis. And that's what I'm going to go through with you right now to show you how we've seen certain things that are challenges within the community and what are some best practices to provide community-wise. Okay. So I'm going to move over to why treat mental health and addiction as a whole. So prima facie, when we first started up with respect to Trafalgar Addiction Treatment Center, this was one of the main questions that we asked. We said, are we going to solely treat the cannabis use with respect to Jonathan? So the Jonathans of the world. Are we going to provide, maybe 1 or 2 counseling sessions per week and provide relapse prevention groups so that, this individual refrains from that cannabis use? We, right off the bat, after analyzing that, said, no, heck no, we're not doing that, because we found that treatment is most effective when it actually addresses both sides, right? As you're seeing right here, when it addresses the underlying pain, trauma, and unaddressed mental disorder. Like with respect to Jonathan, I'm not too sure about his history, but those are the things that we start to inquire about. What is his history? Why is he around these individuals? Or why does he have a sense of camaraderie via smoking? Is there some trauma? So that's where we've shifted our focus towards, is the treating the co-occurring or the concurrent mental health as well as the addiction. As one of my advisors and the advisor of the Trafalgar Addiction Treatment Center team, Dr. Christine Corbisson, in one of our clinical consultations in the beginning, she shared with me, actually you have to read it, she said, Nathaniel, when we remove the substance, the depression, the anxiety, the reoccurring intrusive thoughts will go up, right? And as in like fashion, when we address the trauma, the urges and the cravings will go up. So as a result, we need to treat the mental health and addiction as a whole and normalize that, hey, one or the other might go up as we start to treat, right? And that overall provides us with the opportunity to target both sides. With that, as it says here, we are able to now develop the application of skills to actually address the unhealthy behaviors that are bringing about that cannabis use in this hypothetical Jonathan case, right? That is brought about by maybe emotion dysregulation, decreased impulse control, and so on and so forth. Then as we're treating the mental health component, we take a look at some relapse prevention mechanism strategies to have this individual refrain from their substance of choice or even the unhealthy behavior, right? A little bit later on, I'm going to go into some community-based supports after treatment, after the completion of treatment. If you see me rushing, just fire off a text message saying, slow down. Nonetheless, so one way to actually take a look at the best practice is actually to take a look at where would your client be best supported? So right now that you see a screen or you see a slide up of Trafalgar Residence. Trafalgar Residence is our inpatient rehabilitation facility, as it says, located in the lovely town of Erin. I'm not going to read through that with you. But overall, with respect to this hypothetical Jonathan situation, Jonathan, as long as he's medicated and he has that element of psychosis and he's stabilized, he might be better suited for an inpatient facility, right? So that's part of the aspect of what is the best practice in terms of treating clients, working with clients, is what is the best area that or best place of treatment? Is it the inpatient or is it the outpatient setting, right? And don't be fearful as referral agencies or those that are experiencing this, that sometimes you might refer them to the virtual outpatient program. And then we realize, after the first or second day that we're assessing, you might be a little bit better suited for an inpatient, right? So that's where we're going to shift over to, is the virtual intensive outpatient program. So The virtual intensive outpatient program, as it shows here, is titled VIOP. We provide psychotherapy to the majority of Canada, with the exception of Quebec. Again, as a means of best practice, some individuals, a lot of individuals are better suited for this realm. And this is one of the things that we take into consideration when we're doing admission assessments is, hey, this individual, like hypothetical Jonathan, he's starting to avoid, he's starting to use quite a bit. He does have those supports in place to kind of refrain from it. So you know what, I want to target this before it becomes something full-blown as psychosis. Right. One of the huge benefits of the virtual intensive outpatient program, also known as VIOP, is it affords you greater accessibility. We're now reaching pockets of Canada that we once were able to, and even reaching pockets of Ontario, like rural areas and underserved populations, such as the First Nations, that we were not able to do so. Right. And speaking to these underserved populations and drumming up ways to actually have them have access vis-a-vis a laptop, vis-a-vis, communal, community-based places. One of the other beautiful things about this is that with both the inpatient and outpatient is the quickness of being able to get someone into treatment. Within residential, I perceive it's like one day you can get in ASAP. With respect to virtual, we do a little bit of testing of technological software and what have you to make sure that everything is working. And then once everything is working, within a day, so it's typically a day turnaround, this individual's within the program. Okay. Oops. One second, press backspace. Okay. So highlights. So with respect to highlights. So overall, with respect to Trafalgar Addiction Treatment Center, I'm not going to read through all of that. You'll fall asleep. We are a trauma-informed treatment center, both residential and outpatient. Trauma, both big T and little t for the psychotherapists and the clinicians in here. That's what we focus on, is the mental health to quell the actual presentation or manifestation of those difficulties, such as through substance use, right? We are CARF accredited, which means that overall we routinely report and document everything, which is great with respect to the legal realm. So everything is documented, and it's also great in terms of continuity of care, and so much as that if they do choose to go to another treatment place or clinician thereafter, they can request said notes and track their progress from even before treatment to the very end of treatment. Okay. One thing that I'd like to highlight is the level of family support. So one of the best practices within concurrent mental health and addiction is treating the whole organism, the whole capacity. So that's having the parents, the girlfriend, the boyfriend, the whomever in, right? By providing them with their own individual therapy, as well as providing them with their own support groups, okay? We also operate from many different modalities. I'm not going to go through all of them. Majority of you know them: EMDR, CBT, DBT. These are all different practices that we use with different clientele. All right. So we're going to switch over to specialized groups. So what are the best practices when providing community-based support for concurrent mental health and addictions? Well, first and foremost, you listen to what the community has to offer. If you're noticing, like within this pandemic, if you're noticing that there's a preponderance of sexual addiction and sex and love addiction, guess what? We create those groups. And that's what we do here at Trafalgar Addiction Treatment Center. Is that we noticed that, hey, within the past 2 years that there's been a surge of domestic violence, a surge of PTSD in terms of first responder, and a surge of SA and SLA. So within our programming, we've modified and created specialized groups that help to benefit that community, right? We also pair this with the correct clinician that this individual might be working with. So for example, if you have an individual that has just gotten out of the penal system. She, let's say, was involved in human trafficking and what have you, and has those big traumas, those big T's that were perpetuated by males. It might not be best for that individual to see me. It might be best for this individual to meet with one of our highly trained clinicians that specialize in DV and know the acronyms such as HT and so on and so forth. So how do we provide best practice? Is specializing the group, specializing the treatment. Okay. Oops, backspace. Best practices. Time crunch. Okay. So within what you might have learned, or you might have taken from these 11 minutes with me, is that we combine individualized therapy along with group programming in the virtual setting as well as in the inpatient setting to focus on the trauma and to extinguish or to reduce the chances of cravings and chances of relapse. The best practices within groups is to ensure that they're in a safe environment. So we ensure that we have certain rules and regulations that are set up beforehand and are reiterated throughout treatment. One of the largest components, though, is aftercare. Maintenance in terms of concurrent mental health and addiction is of the utmost importance. Why is that? Is because it provides that individual with the opportunity to fall back on someone that is a comfortable, safe face. Right? So we're going to go into our aftercare supports, and you can ask some questions with respect to the earlier stuff. So where do your, as it says here, where do your clients need the most support? Well, overall, Trafalgar, we adopt more of an absence-based approach. We're an absence-based approach, right? Now, with that said, we roll with the client. So for example, with respect to aftercare, someone comes in under the influence. Obviously, that's a big no-no. We will remove them from the group. But just like with therapeutic jurisprudence, right, where basically it's the inquiry of whether the application of laws or rules have a therapeutic, which is a helpful aspect, or an anti-therapeutic, which is it's not helpful consequence. So we take a look at these case-by-case scenarios and say, okay, well, this individual has been doing well up until this point. Let's provide this individual with additional support vis-a-vis individual therapy or one-on-one consultations with a counselor, get them acclimated, and then return to maybe another group, right? This reduces the chances of, in the legal realm known as recidivism, reoffending, or in the clinical realm known as relapse. And that's what we want to try to prevent, is the relapse or the full-blown concurrent mental health and addictions. That's what we strive for here at Trafalgar Addiction. So we do our best to ensure that we can mitigate and we provide that compassionate care as opposed to rigid, out-of-the-box care. Okay. So one aspect of our aftercare is what we call continuation of care. Continuation of care is wherein there are consultations with the addictions counselor, as it says here, scheduled within the first 48 hours of their discharge, and then scheduled on a monthly phone calls for the next 20 months. So for the first 4 months, they have bi-weekly calls, right? And then after that, they have monthly calls for 2 years. All right, this is again to provide an individual with the ability to land back on someone, to reduce recidivism, to reduce relapse, to ensure that you have someone of safety in your corner, that you have that familiar face, that reduces trauma, that reduces return to the unhealthy behavior or narcotic use. And with that, my last 45 seconds is the aftercare groups. Every individual that completes our program is afforded the opportunity to participate in aftercare groups that run throughout the week, in the morning and in the evening. Again, to provide camaraderie, in the case of Jonathan, providing that, that camaraderie and so much as someone that they can relate to, that are on the same playing fields with them in terms of wanting to refrain from substance use. Another last component that I don't have on the slide is, to address the SES. Some individuals come from lower economic status. So guess what? With respect to Trafalgar Addiction Treatment Center, we afford them the opportunity of customizing the program. You don't have to go for a full program. You can go for a relapse prevention and meet with me on a regular basis. And with that, I end my presentation and hand it off to Alex.
Nathaniel, thank you very much for your most informative presentation. We look forward to speaking to you. And Alex Yeaman, over to you.
Thank you, Justice Barnes, and thank you, Nathaniel, as well as Lindsay, for taking us through the clinical and treatment approaches to concurrent disorders. So we have a very good grounding that actually leads conveniently into my topic for today, which is going to be the connection between the courts and community treatment providers. And so I'm just going to take a moment to pull up my presentation here, and we'll get started. Okay. So I'm going to start off by talking a little bit about my role. That'll get us grounded in what my approach is. So I'm a youth mental health court worker with Turning Point Youth Services. And many of you are probably familiar with the role, but I'll give you some details nevertheless. So my job is to establish links between the young person who's been accused of an offense, the court, community-based resources, and legal representatives, so defense counsel in many cases. So at Turning Point, we do a psychosocial assessment with the young person as well as their family, so long as the youth consents to have their family involved in the process. And that assessment informs our community resource plan. So in many cases, we're going to be referring to outside agencies for treatment. So counseling, for example, is a big thing for a lot of the kids that we work with. Many of them require assistance in school. Substance abuse, of course, is a major thing for us too. And so we make these referrals and we'll monitor the treatment plan of the young person. And in some cases, particularly when the young person's involved in our mental health court, which I'm going to touch on shortly, the court will also monitor the case, and a lot of times we'll end up with a diversion outcome. So the youth will have their charges withdrawn for successful completion based on treatment for, substance abuse, concurrent disorders, mental health, you name it. We're there to support it, whatever it is. So I work out of downtown Toronto for Turning Point Youth Services. This is a resource, the Youth Mental Health Court Worker Program, that's available across the province. I believe it's available in about 90% of the courts in the province. So if you're looking to tap into the resource, probably the best bet would be to connect with your local duty council. They'll know the agency that operates the program and will make the connection for you. The program is operated by different community mental health agencies in each neighborhood and each community. So it does vary, it's not one organization. So now that we have a little bit of an understanding about my role, we'll talk just a little bit about the mental health court that I assist in operating at 311 Jarvis. So the Community Youth Court has been operating since 2012. And the goal of the Community Youth Court is to assist young people in addressing their charges in a court that's separate from the traditional court process. So it's operated within the same court building, 311 Jarvis, or these days on Zoom due to the pandemic. However, it's separate from the regular court process. So many of you are likely familiar with standard drug and mental health treatment courts, and this is, fairly similar to standard models. The young person works with the court and the mental health court workers to develop the plan, which I spoke about in the last slide. So coming up with resources that are going to help address some of the factors chiefly related to mental health and substance abuse that would have brought them before the court in the first place. We also want to focus on their offending behavior and taking accountability for the offense. So accountability is actually one of the principles of the Youth Criminal Justice Act, along with rehabilitation. So we try to focus on details of the offense, and we try to focus on some of the underlying mental health and addictions issues that may have contributed to some of the behavior that led to charges. So as mentioned, the young person is going to be accessing community supports. We're fortunate here in Toronto that that can be done quickly and relatively simply. We have a big network of not only community mental health and addiction service providers and other services out in the community, but also we're fortunate to have youth justice specific services. and they don't often have much of a wait list. So if a young person comes presenting with a concurrent disorder, we can get them connected up with a quick referral, typically within a week or two, and they're in counseling pretty much as soon as possible. Huge advantage for the court process because it means that there aren't undue delays in what's going on, and the young person doesn't get frustrated with feeling like they're just mired in the system forever and ever. So as I mentioned earlier, we do a lot of diversion. In the community youth court, most of our cases end up in diversion. We do take on some more serious cases that would not be eligible due to the seriousness of the offense. In those cases, we're just going to be making sure that the young person has a case management plan still and is being supported just as our other clients would be. In these cases, although they can't get a diversion, they may have some features of the outcome mitigated. So, a lower sentence or something like that to take into account the upfront work that they've done. So mental health courts are effective. That's the good news here. We're not doing this all for nothing. Brand new meta-analysis that was published just a month or two ago. So a study of studies that was completed in the US based on 30 American mental health courts showed an overall reduction in recidivism for participants of 74%. So obviously every court has a different model. Some will take only divertible offenses. Some, like our CYC court, will take more serious offenses. But in the States anyways, across the board, this meta-analysis found that 74% reduction in recidivism was present for those participating in mental health courts like this. So pretty astounding number, actually, and something that we're looking into at our court as well. We're doing some research with the University of Toronto to look into recidivism and the effects of our services at the community youth court. So it's something I'll touch on a little bit later as well. So one last point about this meta-analysis, it's not really known what features of the mental health courts are most impactful. So is it, the quality of the programs that's referred to? Is it the actual workers in the court? Is it an adherence to a particular type of model? These are good research questions going forward, but we do know that generally speaking, mental health courts are pretty effective in reducing future offending for participants. So the last piece about the work that I do that I want to touch on before getting into some strategies is our brand new Pathfinder court-based screening and referral service. So this came about a couple of years ago when our program started to notice that, we look at the research that says that 50 to 75% of youth who are going through the justice system are experiencing a mental health or an addictions disorder, something that either has been diagnosed or could be diagnosed but hasn't yet been investigated. At our court, we would be lucky to be seeing maybe 20% of the court population in the mental health court worker program. So pretty clear indication that lots of kids are going untreated, lots of kids are going without the support that they deserve through the court process. And what we came up with as a solution was, instead of waiting for referrals to come to us, we were going to go and get them. So previously we would take referrals from anyone who'd give them to us. Now we go and we actually talk to kids as soon as they've been arrested. So we try to get them on their first court appearance. In practice with the pandemic, a little bit more difficult. We do a lot of calling around to police divisions, calling lawyers, trying to track kids down. It's been challenging, but we found that if we can get them on that first court appearance, we're going to have a very good chance of engaging them and getting them into programming. So what we do is we take about 30 minutes right up front on the first day of court. It's a voluntary service. Kids can do this if they want to. If they don't want to do the screening, of course, they don't have to. If they agree, we do a standardized mental health screening assessment with them called the MAISY-2, which is normed for youth in the justice setting. And we also ask them some other questions on demographic related things, as well as criminogenic needs, which are basically life factors that can predict offending. So once we have the 30-minute screening done, we will make a referral for the kid if they're still interested, if we've kept their interest through the process. So a lot of referrals go to our mental health program because, as I said, estimates are 50 to 75% of young people involved in the system have mental health or addictions issues. We also have a range of other great programs at 311 Jarvis that service youth who don't have elevated concerns for mental health. Pathfinder makes referrals there as well. So this is a fairly new service, like I said. We're still exploring the effects. U of T and CAMH have been kind enough to organize an evaluation, not only of this program, Pathfinder, but also our mental health program and the community youth court. And we're just getting into the process right now. So we're going to have some exciting results soon to be able to report on, are we reaching more of these kids who have mental health issues? Are we getting more equitable access for Black youth, particularly, who had been underrepresented in our programs before? So these were some of our goals going in, and our early indicators are kind of showing us good news. So we're quite excited to see what's happening when this evaluation is complete. So the big takeaway so far has been getting youth the right services at the right time can be crucial. So meeting a client who's in need, who's in crisis, who is sitting in the holding cells at our court, or is at the police station, who we can call up waiting for their bail hearing, is going to be one of the more challenging parts of their life that they've ever gone through. And so if we can be there for them when they're struggling, and we can tell them, look, there's a path out of this through treatment, we tend to find that they really will latch on to that message, and we get quite a bit of success with that. So those are our kind of preliminary observational findings with Pathfinder. So anyways, enough about me and our programs at Turning Point. I wanted to get to some strategies as well that I hope would be helpful for others who are working kind of in that tricky place between the community and the court setting. So, my very first point is, of course, tooting our own horn of doing systematic identification and screening in the courts. So people who are party to the court, defense, lawyers, crown attorneys, judges, justices of the peace, they don't have time nor the professional skills to be screening people and determining, this is what my clients' needs are. We need to be proactive and go out and get our clients and get them the support that they're hoping to find, but don't know where to access. The court case managers can be very, very helpful in terms of navigating not only the justice system, but the mental health system. So, what's out there and available that I can refer to in the community, and what can I tell the youth I'm working with, the families I'm working with, and the mental health providers outside of the system that they need to know about the court process in terms of how to navigate it. So how can we make those partnerships stronger? It's going to be something that's really key. One thing that I think we don't do a good enough job addressing in courts is spending more time on our highest risk clients. So for us, it's youth. And in the youth system goals really revolve around a lot of diversion, and we do a great job of that. So kids with lower level charges, lower risk, get a lot of the attention, and those who have charges that are too serious for diversion and need to go through the standard court process often are missed when it comes to getting the right resources. But really, these are the ones that we should be spending more time on and investing more in, because their needs are greater. And if ignored, 5 or 10 years down the road, these are going to be more serious offenses and more serious mental health and concurrent disorders that we're dealing with. So how do we do it? We want to move the interventions up in the process as soon as possible. So, we've moved it up at Jarvis to the very start of the court process. What can we do to outreach to community though? And, schools, hospitals, children's aid societies, everything like that, who are often involved with these young people before they reach the courts. So how can we push this prevention up even further to make sure that youth are getting the services that they need before they actually make their way to the court? And one thing that we found very helpful in terms of figuring out how to do that, how to do this outreach, number one, but not only that, also how to deliver our programming according to the needs that we have, is collecting data. So through our Pathfinder program, we collect a lot of data in terms of what are the mental health issues we're seeing, what are the criminogenic needs that we're seeing, what are the demographic needs that we're seeing, and how can we address these through programming. So we look at this giant data set that we have of every kid who comes through, and we can make programming decisions based on that. So basically, the key for us is just being kind of working around the edges of what already works in the system. There's a lot going on that is really effective. So the diversion, like I said, for example, but how can we reach those harder to service kids and get them the resources they deserve? So again, bringing the services to them, collecting data, developing partnerships in the community are all vital, and something that we're hoping to do a little bit more of in the work that we do. So with that, I'm going to send it back to Justice Barnes. Thanks everybody for your attention, and happy to answer any questions that might come up in the Q&A.
Hi guys, I want to thank all three panelists. So Alex, that last piece really struck home with me. I'm a duty counsel in Brampton. Just this week, we've been doing a lot of work on exactly what you were talking about. I saw a question from Grace came in talking about accountability. I feel like you addressed that a little bit at the end of your presentation. The diversion program specifically talks about sort of accountability for the criminal offense, but the way that you're able to identify both the concurrent issue, the substance use through your organization is fantastic. So I'll just start with you, but I also want to thank Nathaniel for his work at Trafalgar as well, and Lindsay for your role over at Lakeshore as well. All three presentations very meaningful. I'm conscious of the time. I think a lot of people have booked lunch breaks to view this webinar. So just in a quick 30 seconds and a wrap up, I think His Honor would love to hear for the participants, what's a good takeaway message? Whether you're a client, whether you're a service practitioner, what's a good takeaway, Alex, for the youth? Lindsay for your demographic, and Nathaniel. I'll give 30 seconds each. Alex first, please.
Okay, I mean, I think coming back to collaboration is really important. So 311 Jarvis, we have a pretty strong culture of collaboration, but there's always more to be done. So it just means if we're innovating in terms of how we want to deliver services to youth, it's great, but we need to be able to have everybody buy in. And the court is a unique atmosphere, right? There's duty counsel, there's defense counsel, crowns, judges, justices of the peace, all the other workers that we engage with. So getting everyone on the same page and buying in, or else, your idea won't really go very far.
Alex, you made reference to this meta-analysis in states, the Fox, Miley, Courtright, Wiseman. If you could send it to our group, we'll make it available to the whole audience. Okay.
Absolutely.
Nathaniel, you're assisted by Melissa as well, and she was answering feverishly some questions in the chat. Thank you, Melissa. Your topic sparked a lot of interest. Can you give us a takeaway for how to help the clients and the practitioners in your group? You're on mute.
How to help the clients and the practitioners is overall just providing overall support. It's a never-ending cycle, and so much as that we here will always provide support, providing that aftercare, that maintenance, and building up that asynchronous treatment afterwards, being that hub, right? Someone that you can lean on at any and all times.
Fantastic. Some of the questions came around accessibility, making sure your services are available to the global population, those with privilege, those less privileged. And Melissa addressed those in the chat for those that haven't seen it as well. So I want to make sure that any referrals are appropriate if possible as well. Lindsay, this idea of the sun worker, I'm really interested by that. What kind of characteristics make for a good sun worker? Empathy, what else would you elaborate on that?
So actually in my last role, I worked as the Opioid Navigator at Lake Ridge Health, and it's an interesting role because a lot of it is just identifying people who use substances who come into the department, because oftentimes they're not there for support with their substance use. They're there for other issues related to infection, mental health issues, and that sort of thing. So I think it's like a bit of detective work and a lot of compassion.
Yeah.
So just in terms of like checking out the chat, anyone can access a substance use navigator by connecting with Connects Ontario or 211 Ontario, because the system is a little bit tricky to navigate for lay people who need support. But I think that having, those navigators available through Connects Ontario, there are a lot of supports out there, and it's important that people with concurrent disorders do receive the support that they need.
That's fantastic. And it was also raised in our group chat that Connects has a very helpful application. So if you need to access online as well. I'll turn it over to His Honor. I think that'll conclude today's webinar. I'm sorry for the rushed, compressed panel discussion. Justice Barnes, anything to add?
All right. The two things I want to say as I try to fix my
There you are.
my video. Well, forget it. Nobody needs to see my face. A couple of things. Alex, Lindsay, and Nathaniel, fabulous job. I mean, you give us so much information that we can use. Andre, I do not know how you managed to get through all those questions in 30 seconds, but a wonderful job. There's a lot of interest in this topic. We'll get back to it in the future. With that, I want to say thank you to everybody, and thank you for spending your afternoon teaching us and also listening to us and sharing. So with that, we'll end this afternoon. Thank you very much. Until next month.
Thanks, everyone.